Okay. Tonight's topic, challenging and controversial topics in glaucoma, or controversial and challenging topics in glaucoma, with Greg and Joe. Welcome to the Greg and Joe Sunday evening comedy hour. So hopefully you will enjoy this next hour and 40 minutes. We will have some discussion, Greg and I, and when you have questions, put them in the chat. We'll be happy to talk about them. Now, these are my disclosures. I'm the consultant or Speakers Bureau or Advisory Board for a number of companies, including Novartis, Ocular Therapeutics, Allergan, Glaukos, Bausch & Lomb, and Sun Pharma. But I don't have any interest in any products that we might be discussing tonight. And I am a co-owner of Optometric Education Consultants with Greg.
And my disclosures are for tonight would be the Allergan, Bausch & Lomb, Aerie Pharmaceuticals. Again, I have I've lectured for them, received, maybe been KOL for them, but I have no long financial obligations with them, and this talk will not be influenced tonight. And as I mentioned, many products and instruments and companies, that it's not going to influence the way I do tonight's education.
And another mention that any products that we may mention or any product we may not mention does not imply superiority or inferiority of any product. They're just based upon our experience. So first thing that is very controversial is what do you do when you see a disc hemorrhage in a patient you believe to be glaucomatous? Either you're diagnosing them or you're managing them. And with that, I think we're going to start right off with polling question number 1. When a glaucoma patient develops a disc hemorrhage, it definitely means progression of the disease.
So Joe, as they're rolling in here, I have a question that comes in just with more housekeeping. Does the video need to be on for non-Florida CE credit? And the answer to that is no. Again, this is for Florida. This is a regulation. Obviously, we do CE from a lot of states. As long as you don't have a Florida license, you don't have to have your camera on.
And a question that was in the chat before we got started was, what about COVID vaccine and optometrists in Florida? And the answer is, I don't know. I don't know where or when I'm even going to be getting mine. I think people who are affiliated with hospitals, from what I've seen on Facebook, people that I know that are at Emory University, Mayo Clinic, Einstein Medical Center, these optometrists have gotten already.
Yeah, so I can say too, Joe, they're probably asking, where does optometry fit in? And I can tell you, I do a lot of state association work, and I spoke with our executive director about this in Pennsylvania. And I know that the state association for Pennsylvania is doing it, but he's also a part of the executive director groups, and all state associations are working hard to try and get optometrists as high up on the list as possible for those who want to get it.
I'm sorry, Greg, did we share the results of polling question number 1?
I did not yet. We've got 96% in that little sidebar. We got it up to 96%. So that's great. I'm going to end it, and then I'm going to share it. And you can see here, it's a pretty almost an even split. Some people agree at 54 and disagree at 46.
And interestingly, personally, I was in one category, and I actually flipped to another category, and I will explain that to y'all in just a little bit. Now, not all hemorrhages of the disc are actually disc hemorrhages. There are other things that will cause hemorrhages on the optic nerve, but they may not be associated with glaucoma because there are some very, very characteristic features of the glaucomatous, or what are known as Durant's hemorrhages. These are going to be typically inferior temporal, superior, and superior temporal, which correspond to the susceptible areas of the optic nerve where notching and nerve fiber layer defects occur. And this will account for virtually all true glaucomatous disc hemorrhages. I think that we have come to the conclusion, based upon enhanced depth imaging OCT, that there is a mechanical shifting of tissue where these disc hemorrhages are occurring at the level of the laminar cribrosa. Now, these are very characteristic type of disc hemorrhages. You can see they're going to be small. They're going to be flame shaped, typically in the nerve fiber layer, though you may see one on the optic disc as it is resolving. They're going to be contiguously at the neuroretinal rim. They'll be in the nerve fiber layer, and they'll generally be smooth. And all these glaucomatous disc hemorrhages we can see are inferior, inferior temporal, superior, superior temporal. Now, in terms of progression, my belief had always been progression is something that doesn't revert back, i.e., a visual field defect that is truly advancing doesn't go away. It doesn't get better. Nerve fiber layer defects don't go away. They don't get better, nor do notches in the neuroretinal rim. But a hemorrhage of the optic nerve will go away in about 6 weeks. That's why they're easy to miss. And we can actually, if we're not looking at the patient frequently, we can miss the disc hemorrhages. And if we're not taking photographs, we can easily miss the disc hemorrhages. So that's ephemeral. And they're not always associated with changes in function, such as change in the visual field. Now, it's always been a challenge as to what caused the disc hemorrhages. Was it an ischemic phenomenon or a mechanical phenomenon? And as I was saying earlier, it looks as though it's a mechanical phenomenon. Enhanced depth imaging, OCT, has identified changes in the laminar tissue where these things are happening. And it's probably leading to a microvascular shearing of the capillaries in that area. So if that be the case and a shifting of tissue has occurred, then that is actually progression. Something has changed. And I actually changed my opinion during a lecture based upon a question from a member in the audience. Now, we used to think, or people that you would speculate these may actually be ischemic, and I don't think there's as much support for these being ischemic for a couple of features. One, when they recur, and they do recur, they tend to recur in the same place, the same very general area, which is where that tissue is already susceptible. Two, if they were ischemic, we see a lot more bilateral disc hemorrhages, which, though they do occur, they're not as common as unilateral disc hemorrhages. And they would theoretically occur anywhere on the optic nerve if it was ischemic. Greg, do you have any thoughts or comments here?
I do. Can you skip back a slide? So you hear Joe and I kind of easily roll off of our tongue. We always kind of say the glaucoma prone zones. And really, this is nice because Joe has the arrows when he says superior, inferior, or inferior temporal or superior temporal. Really, this is where we see notching of the rim early in the disease. Obviously, as the disease advances, it can be everywhere. But we always talk about this glaucoma prone zone. This is the glaucoma prone zone that we talk about. And then the other pearl that I like pointing out with disc hemorrhages is it's usually right adjacent to already existing damage. So I'm not sure, Joe, I'm not sure if they're seeing my pointer. Are you seeing my pointer on there?
I am not.
Okay, so let me request control because I think it will show up then, but then you'll still be able to move the slides. So where I was pointing, now can you see it? Are you able to pick it up?
Right now we're not.
Okay,
it's not picking up yet.
Maybe the audience can tell me since we're sharing remote control. But right in this superior green area, inferior green area, that's the glaucoma prone zone. Now go ahead to the next slide, Joe, if you would. And I think this middle one down here, Joe, this bottom, if you can show that disc hemorrhage, and then right just kind of inferior to that, you can see that kind of wedge defect. And you can kind of see how it's just adjacent to it. So it's usually kind of spreading of the, if it's the initial one, then it's not really spreading. But when you start looking at these, you'll see that there's already kind of, when you look at a photo, nerve fiber layer dropout, this wedge defect, not the pseudo wedge defect. And it's usually right adjacent, like that one down there that Joe's pointing to. And it's kind of spreading and then progressing. That would be my 2 cents, Joe.
Okay. Now, there are other causes of disc hemorrhage. Posterior vitreal detachment is actually a very common one. As that Weiss ring pulls free, it'll tear some superficial disc capillaries, and it tends to end up like in the cup. And that I've usually seen those actually in the cup itself. Hypertension, anemia, diabetes, vascular occlusion, subarachnoid bleed, as we see here, In Terson syndrome, it is juxtapapillary, but it is deep blood. That is subretinal, sub-RPE blood. Here is one that was from a PVD, a large cup to disc ratio. One might say superficially, no, there's a disc hemorrhage, but no, that's actually in the cup and it's not in a glaucoma-prone zone. And as we see over here, this was a case that was sent to me on the internet for a consult. Yeah, there is a hemorrhage here, inferior temporal, but extends really quite a ways out, and we see this vascular amalgamation of what is collateral vessels, indicative of a branch retinal vein occlusion that is resolving. So we have to really look at these to determine if they're actually true glaucomatous disc hemorrhages or just merely hemorrhages of the disc that occurred from some other reason. So make sure all those glaucomatous characteristics are actually indeed there. Now, I did talk about this already. Are disc hemorrhage a risk factor for progression or actual progression? Greg, you got my opinion. What is your opinion on this?
So the answer is going to be yes. When it's glaucoma and it's this disc hemorrhage that we were just talking about, it is progression that's out there. However, it could be someone that's just has not been treated. That's what it could be. Also, I've had that happen before. A patient comes in, they're there, their pressure's up, you dilate them, you see a disc hemorrhage. Well, it's actually progressing, so it's not. But it's it's just but they're not treated either. So they're not controlled. So when I see a disc hemorrhage, what I kind of look at it when it's glaucoma, it's progression. There's a few things that I need to do. Reevaluate the therapy that I'm doing, making sure that their glaucoma is controlled, that's out there. So anytime you see a disc hemorrhage, yes, progression, reevaluate your therapy, or see if the patient's able to take their drops. We know that there's always an issue with compliance. It could be that the patient, didn't take their drops for a couple months. They knew they were coming in, so they started taking their drops. So,
yeah, I agree. I now agree that it's progression, but again, that's predicated by the fact that we're sure, and I said I think the evidence is there, that this is due to a mechanical shifting of tissues, shearing off some small, deep disc capillaries. So based upon that, I agree. Now, the other features of visual field loss may not come for quite a while, and may actually never come. There may not be enough compromise to the nerve fiber layer to justify a change in the disc, nerve fiber layer, or visual field. Maybe there's enough shifting of tissue that the vascular supply was compromised briefly, sheared, so to speak, but the axon still survived that shifting tissue. So the change, the functional changes and some of the other structural changes may take a little while to occur, if they occur at all. Now, what do we learn from some of our major glaucoma studies? In the early manifest glaucoma trial, the disc hemorrhages were predictive of progression, but they also found that not every eye with glaucoma develops disc hemorrhages, and I have to agree with that. And there are patients I've seen for many, many, many years, upwards of 20 years, and I would look at them 4 times a year. I never saw a disc hemorrhage, and other patients I would see probably 2 disc hemorrhages a year when I looked at them. And they found that in this study, lowering pressure did not stop disc hemorrhages from happening. Now, keep in mind the early manifest glaucoma trial, there were standard treatments. They had laser trabeculoplasty, and that was argon laser trabeculoplasty, and they had betaxolol. So maybe that 25% pressure reduction wasn't sufficient. So their conclusion was not every eye gets disc hemorrhages, and you can't stop disc hemorrhages from occurring by lowering pressure. But our goal is not to stop disc hemorrhages from occurring. Our goal is to stop that laminar tissue from shifting and compromising the ganglion cells. I mean, do you agree?
I do. Yep.
And the ocular hypertension treatment study actually showed us that we really miss these things very frequently. In this study, about 84% of disc hemorrhages were actually missed on clinical examination because patients are sometimes not fixating. We have issues where we can't hold a steady gaze. They are small. They are easily overlooked. What they found was in this group, the majority of the disc hemorrhages in the study was actually identified by stereoscopic photos by technicians in a reading center. But they did identify that disc hemorrhages and ocular hypertension eye conferred a pretty significant increase in the risk of change to open angle glaucoma. But one thing to understand is the vast majority of these patients in the study who had a disc hemorrhage from ocular hypertension really haven't experienced an endpoint of optic nerve or visual field change. And if you think that disc hemorrhages are easy to overlook, so are retinal nerve fiber layer defects. They're very hard to look at clinically. I've had many instances where I've tried to demonstrate it to students and residents, and I just really wasn't able to do it, even though we knew that it was there. We look at the photographs, and particularly when you use the red-free filters, they show up really well. So understand the camera is your friend. Take pictures and look at it, looking for those disc hemorrhages and those clinical nerve fiber layer defects. Greg, how often do you photograph optic disc in glaucoma?
Every 12 to 18 months.
Is there a reason you choose that, or is that just your gestalt?
Well, one, I know the photos are still the standard of care. I still keep a dashboard of all my glaucoma patients. I like to make sure I write down when they're dilated, when I did an OCT, when I've done a visual field, gonioscopy, what their Tmax is, what their target pressure is, when photographs have been done. OCT angiography is another one that I like to know when it's done. I think I'm doing cornea hysteresis now. I like to at least write down that cornea hysteresis can vary. So I do like to have that kind of there, but being that it's a standard of care, I like taking photos because I can't tell you how many times I've gone back and looked at photos and said, oh, look, there's a disc hemorrhage there. So I like having disc photos. Joe, you're talking about nerve fiber layer here, and you might be able to help. There was a question that came in. It was sent as a direct message, not to everyone. And it's kind of fold into what you're talking about here. So just kind of massage this in. It says nerve fiber layer drop out further from the disc. And I might have said that quickly when I said about that pseudo nerve fiber layer, but that it says nerve fiber layer drop out further from the disc, nerve fiber layer robust, but can see dropout at the extent of the nerve fiber layer further out. Is that nerve fiber layer dropout? And so kind of fold that in, because I know we can talk about that.
Oh, that's a great question, and I think it's a great question that's very well worded as well. And the answer is no. There are anatomic variables that are called pseudodefects, and you may actually see something out here that appears to be a nerve fiber layer defect, but the nerve fiber layer striations between there and here are still pretty robust, and that's just an anatomic variant that has no functional loss at all. In order to actually meet the criteria for a nerve fiber layer defect, as we see right here, it has to be at least as wide as an arteriole, and it must reach all the way back to the optic nerve. And if it doesn't, it falls in the category of a pseudo defect, and that's actually reasonably common when you look at photographs. Now, this is an example of a patient who was ocular hypertensive, and we can see that there is a small inferior temporal disc hemorrhage amongst it's a very large nerve and a very robust nerve fiber layer. And what happened about a year later was now we have a clinically defined retinal nerve fiber layer defect that we didn't have earlier. And I can tell you everything that we talked about earlier, PVDs, hypertension, anemia, other things that cause hemorrhages of the disc will not cause this to happen. This is a feature pretty much solely due to glaucoma. Greg, you want to add anything here?
No, that was all good information. Nothing to add. Other than the handout was launched a few minutes ago, and I'm going to relaunch it again.
So one of you are wondering, is this a true glaucomatous hemorrhage in an eye that looks otherwise normal? A year later, when you see it, that wasn't hypertension, it wasn't diabetes, it wasn't a PVD, that was glaucoma. He's a 55-year-old male who I saw in 2012, saw for a number of years. Correctable to 20/20 in each eye. Here's 27 and 30 in the right eye and about the mid-teens in the left. We can see on his OCT. He looks pretty abnormal in the right eye and fairly and reasonably normal in the left eye. And what do we see? We take a look and he's got a massive nerve fiber layer diffuse atrophy type of defect with a significantly notched neuroretinal rim. We can see the extent of the visual field damage. But what I want to point out here is he's got a disc hemorrhage. And associated with that disc hemorrhage is that large wedge defect. And Greg, I know you like talking about this and the juxtaposition of one to the other. So why don't you take that over?
So yeah, so right here, I think people are telling me they can see my my pointer. So right here is the nerve fiber layer dropout. And as Joe was talking about, it's widening out. So it should get wider as it goes out, and it does. And as it goes all the way back to the optic nerve. But then if you see this hemorrhage right here, it's adjacent to all, this is good tissue over here. And then this is damaged tissue here. So it's kind of spreading. So that kind of helps us out with knowing that the glaucoma is progressing. So definitely glaucoma progressing in this patient's left eye. That's a great picture of it, Joe, to show that. Thank you.
Obviously, we treated him. He dropped into the mid-teens, a little bit more pressure, not a little bit less pressure reduction in the left eye. And he had a disc change in his left eye. We amplified therapy. And we finally get him down to pressures of about 10 in each eye. And, his visual field has maintained over the course of several years that I was seeing him. But what I want to point out is there's a disc hemorrhage originally. We see the wedge defect, and we have another disc hemorrhage kind of juxtaposed. We can see the nerve fiber layer defect is actually broadened. Do you have any comments on that, Greg? Or
nope, we're good. Okay. And some people are saying they don't see the pointer, so maybe just kind of point it out, Joe. What I'm showing there. So
okay, I think I am pointing it out. You're not seeing it?
Nope. You're good. I just the last time whenever I was pointing it, people said they couldn't, or one person said it. So that's it.
So what do I do when I see a disc hemorrhage? Oh, that's a very good question. The answer is it depends. If their treated pressure is in the high teens, this is in making the supposition that this is a person who is already on therapy. Okay, if we have progression in terms of nerve fiber layer, OCT, or visual field, obviously we're going to want to increase therapy. If there's a risk of visual disability, we want to increase therapy before they actually show any other changes. Now, if I don't have any of the above, we can either increase the therapy based upon what's happening in the lamina corrosa, or we can actually monitor for the nerve fiber layer or the visual field changes. But I can tell you, when you're in the high teens, there's something that we can do. We have some medicines out now that actually work in the statistically normal ranges, such as the Rho kinase inhibitors, and there's a bit that we can actually do. Now, what if they're already in the low teens? That's a bigger challenge. I would say I would probably monitor for progression of the nerve fiber layer visual field if it's safe. Okay, if it's safe to do so. Now, if they have shown change in the nerve or visual field, or they're at risk of visual disability, it's hard to lower pressure that's already at 12 or 13. So at what point do we recommend surgery? Well, there's risk from surgery, and at some point, some of these patients may actually have as much risk of vision loss from the treatment as they do the disease. Greg, how do you handle these two situations?
Joe, go ahead, because I'm trying to troubleshoot someone here. So
okay.
Please do that.
All right, so The answer is it all depends. It depends on where the patient is in their life expectancy, the severity of the disease, and the pressure at which this disc hemorrhage is occurring. If it's occurring in the high teens, there's a fair amount that we can do. If it's occurring in the low teens, there's only a very little that we can do medically. Lasers will probably not lower pressure significantly, and actual surgery carries a risk of subsequent visual disability. So it's a very tough situation when we have these disc hemorrhages. There's no absolute right answer that applies to each patient. So what are the new medications and where do they fit in? I hope you're ready, Greg. We're up to polling question number 2.
Yep, we're all good. I'm back. I just had a troubleshoot for a person. So,
okay. What medical therapy should we start glaucoma patients on? A new branded medicine, a branded medicine, or generic medicine?
And I modified that polling question, Joe, because there's new branded, there's kind of old branded, and then generic. So.
Okay, we're getting through our audience. People responding well.
And I'm not sure if we're going to get to it in the part of the talk, but what about SLT as the first line of treatment? I'm not sure if that's in here anywhere, Joe.
Well, SLT is absolutely a potential first line treatment. In the practice where I work, it is given to patients fairly frequently. It is ephemeral. It doesn't work on every patient equally. There are paradoxical pressure increases on some patients, but typically as a primary therapy is probably as good as one bottle of medicine. If you get 5 years out of it, that's very good, and you may be able to repeat it one more time and probably get a few more pressure points. That's my sense on SLT, but it is a potential primary therapy.
And I agree. And one of the clinical pearls that I can point out, at least what we do in our office, is we like stopping it if the nerve can withstand it, the prostaglandin analog, 2, 3, or 4 weeks out. There are some thought processes that the prostaglandin analog and the SLT kind of work the same way. So stopping that make it a little bit better efficacy. My comment would be, I'm not sure. I have a Pennsylvania license and an Oklahoma license, but I practice solely in Pennsylvania. If I moved to Oklahoma, what would I do more SLTs as primary therapy? It'd be kind of neat to see which way I would fall on that fence on that question. So with that being said, Joe, from our polling question up here, what medical therapy should we start? New branded was 3%. We have branded at about 43 and generic at 54.
Very good.
I'm going to, you know what? Let me share it. I guess I was reading it and I guess I should have been sharing it. So here, everyone, sorry about that.
All right. Well, the newest class we have are the Rho kinase inhibitors. Rho kinase is an enzyme, and that enzyme will actually cause contractility of the trabecular meshwork cells. So by inhibiting that enzyme, it actually relaxes the stress fibers and the actin and the focal adhesions in the trabecular meshwork, and actually makes the trabecular meshwork more compliant and allows it to process aqueous better. And this is unique in that it's a pathway that has not been exploited except for pilocarpine and laser trabeculoplasty. So the traditional outflow or the major outflow of aqueous, the trabecular meshwork, is being more exploited by these newer medications. Now, what we have is NETARSUDIL, and that is RHOPRESSA by trade name. And it claims three ILP lowering mechanisms. The rho kinase inhibition does relax trabecular meshwork, increasing outflow here, making it more compliable and able to process the aqueous. Norepinephrine transporter inhibition seems to reduce some fluid production, but it's not a major component of the action. And the rho kinase inhibitor appears to lower episcleral venous pressure. And by lowering episcleral venous pressure, it removes some of that backflow and resistance for aqueous to get into Schlemm's canal. So these are potentially three mechanisms of action here. Tell us what you think, Greg, of RHOPRESSA.
Yeah, so RHOPRESSA, first of all, it's I hate saying this word with the novel coronavirus, but it's the first novel medication we've had since like 1995. We've had other medications come out that have, since the latanoprost or since the prostaglandin analogs. We've had carbonic anhydrase inhibitors and alpha 2 agonists, alpha-GAN and Trusopt and Azopt. But those are all kind of Me Too drugs. They were already used in medicine elsewhere. NETARSUDIL, this molecule, was truly targeting the trabecular meshwork. And Dr. David Epstein, who has since passed, this was his goal, was to target the trabecular meshwork and find a way to expand that trabecular meshwork and allow more flexibility, opening up the pores of the trabecular meshwork and allowing that aqueous to get into Schlemm's canal into a collector channel. My clinical pearl on NETARSUDIL is that it lowers a low IOP. Study after study shows that it will lower 5. When it works, it lowers about 5 to 6. It doesn't matter if the pressure is 30. It will lower about 5 or 6. If it's 20, it lowers about 5 or 6. If it's 16, where we all have these problems, we all know how easy it is to lower a high IOP. Someone comes in at 32, they're usually going to put them on a prostaglandin analog, and you might even see an 18. You're going to see 22, maybe 21. But if you put them maybe on the NETARSUDIL, you might see a 24, 25. But what about that person that comes in at 16? You put them on RHOPRESSA or NETARSUDIL product, and all of a sudden now they come in and they're like 10 or 11. So what I can tell you is that it's really, really good at lowering a low IOP. And those would be my comments.
What about the adverse effects, the redness and the vortex keratopathy?
Yeah, so there's one new finding that it's the same exact side effects that you get with amiodarone toxicity. Is you get this phospholipidosis, and I'm going to steer away from calling it a vortex because I had this LOL moment in front of the patient, right? I do a talk, systemic and topical side effects of pharmaceuticals. I do it with a pharmacist. Sometimes I do it solo. And, we're talking about NETARSUDIL, how it makes a red eye. My first comment on that's going to be that if you just give it a few weeks, 3 or 4 weeks, it usually eases up. Then we go in and we say, hey, this drug, this pharmaceutical creates this kind of amiodarone, this verticillata, right? That's what it's called, verticillata kind of keratopathy. And it was the same phospholipidosis process that amiodarone creates. So the first time I thought I was going to see it, I thought it was going to be in this nice whirl-like pattern. It's not, because we're dropping it on the eye. We're not taking it internally, allowing it to kind of come through the way the cornea epithelium develops. So I'm looking at this patient and I'm like, what is all this pigment? What is all this stuff? And then all of a sudden I do a little LOL and the patient's like, what's going on? Why are you laughing at me? And I said, I just had like this epiphany, and I took a picture of it. and I have it in my office, and I have it in the complications lecture. I should probably put it in this lecture for us, Joe. But it's not this kind of vortex pattern. It could be any type of pigmentary pattern that's out there. And the other one that they'll talk about, if you read the package insert from ARI, it will say subconjunctival hemorrhages. And I've seen a couple of hemorrhages, and maybe that's how it made it to the package insert. But I believe what we're seeing with that is more vasodilation. And this drug is the only drug that I'm aware of that can actually help with the episcleral venous pressure. Remember, once it goes out through into the Schlemm's canal into a collector channel, it then goes into the episcleral and then the venous system. And it has actually been able to show that it can lower the pressure there, and it creates a little bit of a dilation. And that's why, you can get some, I've seen pressures of 8 and 7 with this medication, because this medication can actually lower the episcleral venous side of this. So those are kind of the three side effects. There's subconj hemes, there's verticillata, and the redness. Redness, I'd say just give it time. The verticillata, it's not going to be a whirl-like pattern. And the subconjunctival hemorrhages, I think, is more of a vasodilation that occurs.
And I think I have actually seen with this molecule, the hyperemia that occurs is more notable and significant than with the prostaglandin analogs. But I've also seen that it dissipates probably better than the prostaglandin analogs. So it comes on very strongly, but within about 10 or 11 days, patients can actually be well back to normal. Now, ROCKLATAN is a combination medicine, and it doesn't have a beta blocker in it either. There are a couple of things that make it unique, and it's the first that we had that involves a prostaglandin analog. So this is a combination of NETARSUDIL, which is a Rho kinase inhibitor, and LATANOPROST, a prostaglandin analog. And by putting the prostaglandin analog in there, it is essentially a 4-mechanism action. The same 3 previous mechanisms that we just discussed with NETARSUDIL. In addition, the prostaglandin analog is enhancing uveal scleral outflow. So 1, 2, 3, potentially 4. But definitely it's enhancing trabecular outflow as well as uveal scleral outflow. And this is probably one of the most effective medicines that we actually have available to us in a topical form. When we look at the clinical studies comparing the fixed combination of a Rho kinase inhibitor and a prostaglandin analog together, you can see that they are significantly better than either product alone, either RHOPRESSA alone or LATANOPROST branded Xalatan alone. And there's really a pretty significant difference there.
Joe, go back to that. I can make a comment on that.
Yes, go right ahead.
And the comment will be, when we talk about RHOPRESSA earlier, NETARSUDIL just by itself, when those medications come to market, they have to pass an inferiority test, which just means it has to be equal to or better than timolol. And that's with any single agent that comes out. When it comes out to be a combination, whether it's Simbrinza, whether it's COSOPT, it has to pass what's called superiority. And that's why this is, a lot of people will say, why can't we get, in other countries, they have LATANOPROST or Xalatan with timolol. They have these other medications out there. This is the first prostaglandin combination in the United States. And that's because in the United States, if you're taking 2 separate molecules, putting them in the same bottle, it has to pass the superiority of both medications at all time levels. And that's why we all know that most of us know that there's very minimal or no beta blocking activity at night. So whenever you try and use the Xalatan and timolol combination at night, there's no beta blocker activity. So then it has a tough time beating the superiority side of it. So what we're showing here, if my cursor is showing up, is, let me go back now, is that all time points here, this ROCKLATAN was superior over, in orange here, the LATANOPROST and the RHOPRESSA which is in blue. And that's how it was the first prostaglandin analog combination to make it to market and why others can't. So a lot of people say, why can't this happen? That's the reason why. Superiority at the FDA level.
And we look at target pressures or pressure reduction, absolute magnitude of pressure reduction, going under 18, 17, 15, 14. You can see that the combination, trying to get a lower than 14 pressure reduction, about a third of those patients would make it with ROCKLATAN, but significantly lower number, about half of those would make it with either a RHOPRESSA or a LATAN alone.
It lowers a low IOP.
Again, very similar to what we just discussed, hyperemia, okay, petechial conjunctival hemorrhages, this VYZULTA. Greg, it's been said that the corneal pigmentation is reversible. Do you feel that it is?
Yeah, it is. I've actually had a couple patients that just for the fact that we did some surgery on them, did a cataract surgery with a Cahook dual blade that we were able to get them off of medication. And it did reverse. Did it reverse 100%? Yes. Or did it reverse 100%? No, sorry. But did it get significant reversal? And the answer is yes. Another thing that I'd like to point out is when we talk amiodarone and we want to just say verticillata keratopathy, and maybe in amiodarone we can call it vortex. And since I was shocked by it when I first saw it, I'll just call it verticillata type of keratopathy. When it comes to the NETARSUDIL product, when we talk about amiodarone and we talk about verticillata keratopathy, there's 4 stages of it. Everything in medicine has 4 stages, right? 1, 2, 3, and 4. 1 and 2 do not cause vision loss. I've had patients on this anti-arrhythmia doing a corneal topography showing all the irregular astigmatism. They're in stage 3 or stage 4. I call the cardiologist up, explain to them that they're in vision loss. They're like, yeah, we were taught it can never be. Well, I've had a lot of cases like that. We stop it and their vision gets better. Talking to the MSL for the pharmaceutical company at RHOPRESSA, MSL is the medical science liaison, right? Those are the people that you can go and talk to off-label stuff, so on and so forth through. When the representative comes in, if you ever want to get them out of your office, just start talking off-label because they have to stay on label, right? That's a little joke. But anyway, that's why sometimes you can't talk to the representative off-label stuff. But on off-label MSLs, you want to get down into the weeds. I've asked the MSLs, have they had anyone reported to them that's been stage 3 or 4 with RHOPRESSA or ROCKLATAN? And the last time I checked with them was about 6 weeks ago. They had not. So that's kind of cool, is that the patients have not had any stage 3 or stage 4. I'm sure maybe someone out there eventually will have one or hasn't been reported, but it's not a high incidence that's out there. And yes, Joe, reversible, but long drawn out answer of, maybe not 100%.
Okay. So it really works well. Patients can tolerate it very well. There are some issues with blurred vision, and I have come across this, and there really is no explanation. It can just sometimes blur the vision a little bit. Generally well tolerated and is completely reversible, but it is not due to a keratopathy.
I think the blurred vision comes from whenever you talked about that one mechanism. It's in the endothelial cell pumps. They start to be a little bit, disrupted, and then it takes a little time for that cornea to kind of to recalibrate. So, FYI, that's just my humble opinion.
We also have VYZULTA, which is latanoprostene BUNOD. This is a nitric oxide donating prostaglandin. I'm not saying nitrous oxide, that's for dental use, but it's nitric oxide. And nitric oxide is ubiquitous in maintaining cellular homeostasis, and it is diminished in glaucoma eyes. It's been up to about a 40% diminishment of nitric oxide in trabecular in in the trabecular meshwork in glaucoma size. And nitric oxide is actually being produced by Schlem's canal. So what will happen in that situation is it leads to a stiffening of the trabecular meshwork, less contractility, and lack of nitric oxide stiffens up that trabecular meshwork. By having nitric oxide replaced into the system, it actually leads to a better compliance and more trabecular outflow. So again, prostaglandin is the uveoscleral outflow pathway, and this is also enhancing trabecular pathway. Now, nitric oxide is a gas, and the only way it can be delivered is if it were attached to another molecule. It could have been attached to a beta blocker, a carbonic anhydrase inhibitor, an alpha adrenergic agonist, but it was attached to a prostaglandin analog. And this is it's not a dual medicine, but it's dual mechanism. So when it gets into the eye, this latanoprostene BUNOD, it's going to metabolize into these two moieties, latanoprost acid, which we all know how that works, and butanediol mononitrate, which is going to release nitric oxide and also break apart into a metabolic waste product, and it's going to enhance trabecular and Schlem canal outflow. So as I mentioned, nitric oxide is an important physiological signaling molecule that is important in IOP regulation in normal healthy eyes. And it's going to enhance the outflow through trabecular meshwork and Schlem's canal. Now, compared to branded Zalatan, it will give about a 2 millimeter pressure reduction greater, 1.2 to 2 millimeter pressure reduction greater. And one might argue, well, that's not a big difference. Well, in some patients, it can actually be beneficial, but remember, there's also super responders out there. People who have 3, 4, 5 or more pressure reduction compared to branded Zalatan. And I'm saying it was actually compared to branded Zalatan, not generic latanoprost. Greg, what are your thoughts on VYZULTA?
I like the medication. I'm now able to use it a lot more in my area due to the fact that it wasn't well covered in Pennsylvania at the insurance level. Even with failures and prior authorizations, and then something recently changed, and in the last 3 or 4 months, that we were able to use it. And maybe it has to have a failure, I believe, at least in Pennsylvania, where I practice. It's got to be a failure on at least another prostaglandin analog. And then the prior auth actually goes through pretty smoothly. Now, with that being said, I like using prostaglandin analogs and exhausting all options before adding a second medication. So if I have someone on generic latanoprost and they're not controlled, I'll go maybe to branded prostaglandin, and really the only one that's still out there kind of holding its own is Lumigan. And then if that fails, then I'll move into something like VYZULTA here, Joe, before adding a second med, just trying to get that strongest foundation that's out there before adding that second med and getting them on a prostaglandin analog, and maybe just keeping them, because you said 1 or 2 points might be enough just to kind of get them back to target.
Greg, do you have any hesitation or concerns about generic medicines?
I mean, do I have concerns? Yes. Do I have hesitations? I mean, I don't not use them, but there are some, I guess, differences that we just need to be aware of. And I'm going to just say that and preface that with when it comes to eye drops. So I think when people ask that question, what about generics versus topical medications? I think that in oral medications, the variations can be slightly minimal. But when it comes to drops, I think there's more concern and more hesitation that I have.
I have fewer hesitations, having been at the university where we're sort of the safety net for people who are uninsured or underinsured or ocularly very unhealthy or systemically very unhealthy, generics are ubiquitous. And I myself, my belief based upon the literature, also supported literature, these medicines work just as well. They're the active ingredients are going to be the same. The inactive ingredients will cause some differences. When we look at the evidence-based literature, you can easily see that there are some studies that will show an inferiority to the generics, but the vast majority of the studies will show that they are functionally equivalent. And these newer medicines, which are great, they are terrific medicines that work extremely well. We're not going to get them covered unless we at least try a generic first. So I don't have any hesitation to use latanoprost or brimonidine or dorzolamide timolol. I myself am very happy. I think they're very efficacious. And the advent of generic medicines have actually enhanced adherence to therapy by about 41% because it's much more affordable for patients.
Yeah, and I'll come back with my thoughts here is that, it sounds like I don't prescribe generics, which I do. I know what my numbers are. I'm probably about 70% generic, probably about 30% branded. And the reason why, whenever it comes, I lecture with a pharmacist and we geek out sometimes about generics versus branded. So the first thing we have to realize is that when a generic comes to market, there's no clinical trials, all right, because they're already kind of been done. It's FDA kind of brings them quickly to market by just kind of visiting the facility and just looking at the formula. Now, when I come to where my hesitation is, I'm not saying I'm adverse, but these are the things that are out there when it comes to formula that's out there, is that sometimes the molecule is not as pure as the original molecule. And with that being, you might not get as efficacious of a lowering. Is it a reason not to prescribe a generic? No, none of this stuff here is generic yes or no. But I think the other biggest thing is, and I think a lot of the audience out here that treats glaucoma will probably subscribe to this, is more in the bottle. The bottles can, I'm not sure what it's called, but when you squeeze a bottle, the flexibility of it, some bottles are stiff, some bottles are hard. And we know that a patient, as they get older, their agility changes and they might get used to squirting a certain bottle. And all of a sudden they get another generic bottle and all of a sudden they squirt it throughout their whole eye. And I've had that happen, right? How many times have we had, doc, I just one squeeze and boom, it was all gone, because now what's not regulated in this generic is the dropper size. So is it going to drop out or is it going to stream that's out there? And then, so that's kind of where I hang out with. There are differences out there, and that's why I say hesitations, but it's not enough that I'm going to say, hey, patient, you have to take this. I'm just a branded type of guy. But I do like the branded medications because I get a little bit more consistency and quality, less variability when that's out there. And then what we just talked about with these other medications, like something like VYZULTA, is that if you just stick with generics, and I'm not saying that's where you are, Joe, but I know there's some people out there, some of our colleagues, I just do generic, that's it, you're never going to budge me. If that's kind of your philosophy, you're going to miss out on some of the innovations, right? Some people might need a BAK-free product, or in this case, what Joe was just talking about with VYZULTA, this nitric oxide part of it. So I think you might miss out on innovations that are out there. So again, I do have hesitation. It doesn't stop me from using them. Obviously, I do it 70% of the time, which is majority.
I'm probably about 85 to 90% on generics myself. Greg, let's get polling question number 3, please.
Yeah, let's. We've got a few. I think we can probably answer this coming up. I got some questions in here. This one is: have ever tried Pazeo in a RHOPRESSA patient? I have not. I might use maybe like an alpha 2 agonist to kind of squeeze those blood vessels down a little bit, but I haven't used any Pazeo. Joe, have you ever used like an antihistamine olopatadine molecule like Pazeo with a NETARSUDIL product?
I have not. You need something that there's more vasoconstrictive, but I myself have not done that.
Let's see. In what trial frame do you use when determining if a medication is, how about ineffective is what they have here, or we can say effective. So you want to take a stab and then I'll color it up or add to it?
Yeah, I like to have about two pressure readings after I start the medicine. I think we've all learned, we've all advocated that you want to get two or three pressure readings before, I mean, if, of course, if it's safe, before we start therapy. I think we also have to get at least two pressure readings after we start therapy to determine if it's effective or not. The effectivity of medicine is not the same between two eyes, and of course the diurnal variation is not that consistent. So we may actually find a medicine that's working, but on one pressure reading it may not actually seem that it does. So I like to have two, and that's usually probably within 3 months after I start the medicine. I'll see them at about a month, and then maybe at 3 months to see exactly where we stand. So I'd like to have two pressure readings after I start in order to make a determination if it's efficacious or not.
And Stephanie, I see that you asked that to everyone, so I don't mind mentioning the name. When I get them privately, I don't mention the name. So, I will probably start someone on a medication, some new therapy, whether it's generic or not, but it's usually a sample from my office. Or if it turns out to be a generic, I'll probably see them back in about 2 to 3 weeks. One that just helps me check to see, make sure they're doing it the right way. They don't have them reversed. This is once and this is three, and they're getting them reversed. And I like to see, as long as they got it correct, I like to see some change. And then if I do, then if it's not at target, then I do kind of what Joe says, stay on it. Let's see if we can, get this down to the target that we want to be. But I like to see some change at about that 2 or 3 week type of period that's out there. And I'm just going to mute that and um, come back up to here. So, Joe, there's a question in here about, and I think we're going to get to it. It says, if a patient has glaucoma and needs cataract surgery, instead of starting treatment, your thoughts on eye stents?
I think that if you're in a situation where it's available and cataract surgery is going to be done and they have glaucoma, or ocular hypertension and they have a mild form of the disease or even a moderate form of the disease, it should probably be done. Rather than having to go back in and do something later on, as long as the eye is open, I think putting a MIGS procedure or a MIG in at that point is probably very reasonable.
Yeah, and I'll just kind of change that up a little bit because someone referred just to eye stent, but don't forget there's a few other types of MIGS procedures that are out there. Cahook dual blade, which is obviously no, or not obviously, but I'll point out that it is, it's no device needed. It's a surgeon kind of carving out, say a couple clock hours of trabecular meshwork, exposing Slem's canal. I've seen that in our office. There's the Hydrus that's out there. And then obviously the eye stent has to be done currently at the time, it needs to be done at the time of cataract surgery. Joe, one more here. It says, I too have had issues with some of the generic products of LATANOPROST, much to my surprise, given the XLT study by Robert Parrish at Bascom saying otherwise. But switching to Lumigan has made a difference in some instances. And I can make comment to that because I do subscribe to that. I have patients that are on generic LATANOPROST. And if they creep up, and I'm not saying if they went from 18 to 28, I'm saying they went from 16 to 19, 20, and I'm sitting at a 17 or an 18 target pressure, I will put them on a branded, which is Lumigan now, branded Lumigan, to see if I can get them down. And I have had success, not say 100% success, but success. But then before going to a whole other mechanism, I would maybe consider adding VYZULTA to it and seeing if I can control them there. And then if I was going to add something, maybe at that point is where I maybe go to ROCKLATAN in that case. But thank you for that comment there, Nader. Joe, anything to add to that?
No, not at all.
Okay, I'm going to launch polling question number 3 since it's been up there for a while. Well, I think we'll see what the audience feels here.
Are generic medications inferior to their brand counterparts? I think you've heard our discussion. What is your sense?
And I think inferior is a strong word.
Okay, we're over 90% already. And most people believe that they're pretty well equal, but there's a significant number. 1 in 4 agree that they don't think they're quite as good. Excellent.
Yeah. And like I said, I think inferior, maybe reword that question the next time, is that I think we should go with the hesitation question. So I don't think that they're inferior. I probably, after you hearing my argument, I wouldn't say that they're inferior. I wouldn't use them, right? I think it's a tough question there to ask. Is that, but are there some differences out there? I think there are.
Greg, let's talk about visual fields. Let's talk 24 versus 30 versus 10 degree fields. What? I'll let you run with this for a little bit.
So first of all, let me see if I can, in my slide, if this advances here, because I think whenever I have control here, then they can see my pointer. So the first thing I like to point out on a 24-2 versus a 30-2 is that a 24-2 goes superior, and I can tell right off the bat, even though this is small, that this is a 24-2, the superior visual field. And the reason being is that it goes 24 degrees superior, it goes 24 degrees temporal, inferior. However, nasal, it does go out to 30 degrees. So whenever I'm doing visual fields, either a 24-2 or 30-2, deciding on whether I'm doing it in the office, I'm going to do a 30-2 on the patient because one, it's a little bit quicker, less fatigue, but you're not going to get the rim defects. And if we're trying to pick up glaucoma early, we know that it picks up on the nasal side. So the 24-2 does test out to the nasal side on that's out there. There's 54 spots on a 24-2. I've never counted the spots on a 30-2. Now, when it comes to if you're doing a Humphrey, and there's some really cool stuff coming out on visual fields in the next few years. Well, actually, this year they've got some virtual reality goggles that are out there. You know, they look like virtual reality, probably not virtual reality, but you get what I'm saying. It's the kind of the goggles. Some really cool different types of way of doing visual fields, but I think most of us are familiar with kind of that Humphrey style. But everything that I teach here tonight can be applied to really any visual field that's out there. Whenever I'm doing a visual field, 24-2 versus 30-2, 24-2, CETA fast or CETA standard. I like doing CETA standard until maybe they graduate. And the reason being it crosses the threshold twice. So if it crosses just once, there's kind of a big variability. I like going first or second. I like doing it crossing that second time. It kind of tightens it up, especially if we're looking for progression in glaucoma. Another thing that we can look for is fovea on, fovea off. I like having fovea on. And really, if the person is 20/20 or better, they should have about a 36 decibel. As the decibel number gets smaller, that means it's getting brighter. So, someone around 32 might have about a 20/30 or 20/40 vision. So it kind of right off the bat kind of shows me how they're getting the test because all that should correlate. So I like fovea on, 24-2, CETA standard that's out there when doing a visual field. Joe, I'm not sure if there's anything out there else that I would talk about at this point. We can talk about mean deviations and pattern standard deviations, but that's kind of the difference between 24-2 and 30-2s. Do you want to take 10-2?
Well, 10-2 is just a more concentrated 10 degree assessment. The points are spaced closer together, and they're really necessary for, of course, maculopathies, but for advanced disease. Now, anytime we have a paracentral depression on a 24-2, 10-2 should be done in addition. Now, once a patient is under 14 decibels, really not safe to drive. And once they drop below 22 decibels, they're meeting the criteria for visual disability. And this is about the stage where we should be looking at 10-degree fields. But here's one of the challenges that I'm still struggling with. I think a lot of people are as well. 10-degree visual fields in advanced glaucoma, how do you interpret them and how do you judge progression now? A paracentral scotoma is anywhere from 5 to 15 degrees from central fixation, from foveal fixation. It can be relatively small abnormality in this nerve fiber bundle region, and it's not generally contiguous with a blind spot. And it doesn't involve points outside 15 degrees that are close to the nasal meridian. Now, of course, central scotomas are in the macular region. The foveal threshold is going to have a p-value less than 5%. Can be associated with a single hemifield or can be paired with another defect. But these are very difficult things to judge progression on. Now, visual fields get worse in 3 different ways. You can have a deepening of an existing defect, an extension of existing defect, and development of a new defect in what was previously a normal area. And this is an example of what I mean. We can actually see there's a deepening in terms of the degree of scotomatous loss here. The pattern hasn't changed much, but it's definitely gotten deeper. Here's a patient I saw some time ago with angle recession glaucoma with a pressure of 47. He was non-compliant with his medicines and declined surgery repeatedly. And he started off like this with a normal visual field, and before long he had clearly an inferior arcuate defect, and he had a density. So he's getting worse in every way. He's getting denser, it's getting larger, and what was normal is now abnormal. Now, glaucoma progression can be, event analyses or trend analyses. Event analysis is saying whether or not the event has happened. It's comparing what's happening right now to some pre-selected baseline information to see, has this actually happened or not? Trend analysis looks at the trend over time. How fast is this getting worse? And they're very complementary with one another. Event analysis tells us if the patient is getting worse, and trend analyses tell us at the rate as to how bad they're getting and how fast they're getting worse. So event analyses are looking at statistically significant events, and trend analyses are looking at clinically significant events. And this is in what is known as our guided progression analysis. And this is an algorithm that looks at visual fields and tries to identify changes that would exceed the 95th percentile confidence interval of patients who would be stable with their glaucoma. So it looks at the baseline. We can see there's a rate of progression or trend analysis, and comparison to baseline, which is what is known as the event analysis, or whether or not it has actually gotten worse, and it'll say likely progression or no progression detected. Now, is this field progressing? As we take a look at it, we see that the patient has what was a perfectly normal field on the left, and we see some deviations on the right. And superficially, we may actually look at this. Greg, is there anything you want to say on this, or you want me to just continue with it?
Well, I would say, and I can't see the numbers up here, but on this, let me just, so people can see where I'm pointing and see if it goes forward. Yes, let me go back. This patient here, when the total deviation and the pattern deviation, it gets worse going this way, the patient is probably a little trigger happy. There's probably a lot of false positives going on this visual field here. And why that happens is because and you can see there's a lot of white washed out defects here. And what happens is when they become trigger happy, it pushes the visual field down, thus taking these, which if we could see the numbers here, these normal numbers get pushed down an X amount, then it flags them as being abnormal. So when I see this, this is probably a trigger happy patient. False positives trash a visual field. I would make my technician, no, I shouldn't say make, I'd make the patient take it again, and I would hammer the patient, and then I would have the technician make sure that they're keeping this patient awake during this visual field.
And that's a very important fact right there, Greg. The pattern deviation is worse than the total, and that usually is a sign that there's a lack of reliability. And also, if you know, it's hard to see, but the mean deviation is actually positive here where it was negative here, and it looks like the patient actually gained about 2 decibels of vision here. And when we repeat it, we can see that it really hasn't changed. Now, is this patient getting worse? Greg, what are your thoughts here?
Again, I think it needs to be repeated. This visual field, if you guys can see, this kind of this perfect horizontal line right here, is below fixation here. So I'm kind of interested what's going on with this visual field, Joe.
I can tell you exactly what's going on here, and I'm going to point out on this visual field, the foveal threshold test pattern was off. But here it was actually turned on, and we can see that it's around 34 decibels, which is actually very good vision. Now, our pattern deviation looks or tells us that this is a patient who probably has a central scotoma, and one would think that this patient has gotten significantly worse, and that's actually not true. What had happened was patient did a visual field and looked at the central fixation. Now, next go around, foveal threshold was turned on. And of course, in order to do foveal threshold, the patient has to be directed to look below that central fixation target at these little diamonds, because that's where the sensitivity will be tested. And this is a person who was not instructed or didn't follow instructions to change his fixation back up to the central. So while this looks terrible and everything it would make you think that the patients lost their central vision. No, the central vision is still very good. They just did not change their fixation. You have to be very, very careful about this with these paracentral scotomas.
So Joe, I'm kind of going to feed off of that because there's a question in here from Jennifer. It says, for a patient, what is the decibel for the foveal? And right in here, Jennifer in the audience, it's out here where Joe has this circled. Someone that's 20/20 should be about 36 to 38. Let me give you a little bit more pearls on a visual field. When you're looking at the raw data here, all visual fields that, to my knowledge, and there's been a lot of new visual fields out there, but most visual fields or all visual fields can test up to 50 decibels of light. All right. 50 decibels is a very, very dim light, right? So the bigger the number, the dimmer the light. Human vision cannot see anywhere from 40 to 50. They test it so that when you go up and you look at this raw data, if you're seeing 40s, 45s, 42s, 43s, you know that this patient is just trigger happy as can be. It's probably not going to be much of a reliable visual field. So to answer your question, 20/20 should be about 36, 37 decibels, maybe 35, but somewhere in that range, maybe as high as 38. But you start hitting 40, that would be someone 19 years old, clear crystalline lens, perfectly clear vitreous. You might get a 40, but that's not who we're testing glaucomatous visual fields on.
And again, very similar. We have two separate visual fields look very different, and one may think that there is a significant change in the subsequent visual field. But again, foveal threshold was off here. It was turned on here, and we can see that the foveal threshold is actually very good, though it looks like the patient has a central scotoma. Now, the patient was directed to look below, as you say, below fixation, for this test, and they didn't change their fixation back. And this is especially common with 10-degree fields. 10-degree fields are extremely hard to interpret. You actually need to have a lot of 10-degree fields. 10-degree fields should probably be done, if you've got a patient on 10-degree, should be done probably every 6 months, because you really need to have a number of these fields available in order to look back. Many a time I've had a situation where it looks like the 10-degree field is getting worse. I go back and I can find 3 years earlier the same visual field. So again, this is a person here. We look at the foveal threshold. It's because the patient didn't change their fixation, or they'll have a slight difference in fixation. Changing in fixation on 10-degree fields is very challenging to interpret, because it may look like the patient's getting worse. The best thing I can tell you to do is you have to have a lot of 10-degree fields. There's no guided progression analysis for 10-degree fields. We have to be able to look at a sequential number of them to see the trend, to see if they're actually getting worse. And here's my clinical pearl. If a patient on a 10-degree field is getting worse, they will tell you even before you do the field. They'll give you information that they're not seeing as well. They're missing more things. They're having more visual challenges. And when they say that, any change in the 10-degree field, I take more seriously. But if I see a change like this and they say, oh, no, there's no difference, I know that is errant fixation. Greg, briefly, what's more important to you, target pressure or peak pressure?
They're both equally important, but I'm going to answer at peak. But before we move on to that topic, let's address some of these comments and questions that are in here regarding visual fields. Amy brings up, what are your thoughts on 24-2C? Nader's kind of the same. As any preference between CETA faster 24-2 and Octopus G program, TOP or top, if you have both units and want to have them an all-in-one visual field strategy, averting basically what you were just saying there, Joe, about 10-2. So for you guys that are out there, and thanks, Nader, I couldn't remember what it was called in the Octopus G program, which merges like the 10-2 and the 24-2. In a Humphrey, what Amy's referring to is taking a 10-2 here. Let's see if I do this and come back. Taking a 10-2, and the names have slipped my mind, but there's these visual field gurus. Like anytime I see an article out there from these people, I'll read about it. And what they've done is they've studied all the 10-2 visual fields from glaucoma, and they picked 10 points. Now, this is speaking for Humphrey, and I'm sure it's very similar to the Octopus G program / TOP, is that they studied the glaucomatous visual field in the 10-2, and they took 10 points that are very commonly damaged in glaucoma, and they merged it with a 24-2. So there's 54 points plus the 10 points. Now there's 64 points. But what it's able to do is kind of a 10-2, 24-2. That's the 24-2C, and Octopus has a very similar pattern. So I think in your questionnator, do you do the all-in-one? Here's kind of what I've done, and this is kind of what's working in my practice. If a patient comes in and they're brand new to visual fields, I still do a 24-2 CETA standard. They need to kind of graduate into these CETA faster visual fields, as what you asked about the CETA faster. And in the 24-2, it's a CETA faster program with Amy's question, is I still have them kind of learn on a 24-2 CETA standard. Once they graduate, I don't mind switching over to the CETA faster. For those out there that have the Humphrey, CETA faster, what they do is they turn off the false negatives and they turn off the blind spot, and it makes the visual field go a little bit faster. But I do like the 24-2C, because you can have a clean 24-2 and a bad 10-2. So glaucoma can show up so what do you do if you have a clean 24-2? You should do a 10-2. So now what I do is if I'm curious about that, like, man, there's some nerve fiber layer damage. Man, there looks like there should be a visual field defect. Yes, Amy and Nader, I will do a 24-2C on those patients, maybe sooner rather than later. So I do like these combined. And yes, I do like averting because it is a nice combination of a 24-2 and a 10-2. So, and Joe, I'm not sure if you have any comments on that, but I do like those programs that they've come up on those visual fields. So Octopus has it, and so does Humphrey.
I was actually on a webinar yesterday with the World Glaucoma Association. The 24-2C came up, and the consensus was the glaucoma specialists who are speaking, who are internationally renowned, pretty much all acknowledge they don't have enough experience to make a comment with it yet. I think it's a very good idea. I think that we need to have a little more time and a little more widespread use to determine exactly where they stand. So Greg, you said target or peak? You said peak is important. They're both important to you, but peak, tell me why.
I like to know where my starting point is. There's at times when patients come in for second opinions, if their nerve is not cupped out, I'll actually ask them to stop their medication, for a few weeks so I can just kind of baseline them to find out what their peak is. I just like to know what their high pressure is, how that's going to help me determine, setting a target IOP. I like knowing what the highest pressure is. I like to know what Tmax is.
Mm-hmm. The target pressure is your clinical guide map. It gives you a good sense of where you want to go. And is it important? Yes, I agree it is important. How do you figure out? Well, that's not really so easy. I too have much more. I have a lot more emphasis on the peak pressure than the target pressure. Both are inexact because a target pressure is really just a guess. But peak pressure is what you can measure in the office at any one time. Are we guaranteeing that number is the patient's peak? No, we can't guarantee that. Target pressure, are we guaranteeing that is the safest pressure for a patient? No. Both are very inexact, but both are actually pretty important, and probably important to actually have in the chart accessible. Because we can be going around 17, 18, 19, 18, 17, 19, 18 on a pressure, and because it's under 21, we think we're doing a great job until we realize the patient started off at a pressure of 22, and maybe we're not doing such a great job. Greg, how do you choose the target pressure?
Well, it's going to go back to visual fields again. There's a lot of things that come into account, but a lot of people like to have some type of clinical pearl that's out there, something that can kind of help them. So I've kind of developed this kind of clinical pearl, this clinical tip that has worked. So the first thing I want to ask the audience out there, just ask yourself, what is the mean deviation on a blind eye on a 24-2? This kind of struck me one day after doing a talk. I was somewhere driving back, and I'm like, you know what? I don't know what the visual field on a 24-2 of a blind eye is. So I walked in on Monday and I walked to my staff. First thing I said, good morning, Sarah. How are you? Hey, can you do me a favor? Go turn on the visual field. Type in 35 years old for me and let the visual field run, and never, as if the patient's blind, they never click on it. Doc, you had a really bad weekend, huh? They kind of like looked at me and I said, yeah, just do it for me. I'm kind of curious. After they did that, I tore it off, gave it to me. I said, now change the age to age 65. In both of those scenarios, the mean deviation on that blind eye was about minus 32, 34 for the 35-year-old and 32 for the 65-year-old. So minus 30 is a blind eye. When I'm treating glaucoma, I don't want them to go from 0 to minus 32 or minus 30, right? So the next question I like to ask is, and there's a reason for this, Joe, where I'm going with this to set a target IOP, is if 30 is a blind eye, is 15 half blind? And the answer is no. Visual fields are not linear. Visual fields are curvilinear, right? So that's why if you have someone with a -5 defect, and Joe showed some pretty big defects there, but -5 on a visual field, people read slower, there's increase in falls, and they leave their house less frequently. Increase of depression. That's just -5. Okay. So whenever I was at the Optometric Glaucoma Society meeting a few years back, they all kind of sat about, okay, what's a mild defect? 0 to 5. 5 to 10 is moderate, and anything above a 10 is a severe visual field defect. So that's how I pick. I usually do not. Do you want here's my clinical pearl. That's why I went through all of that. My clinical pearl is I really don't set a target IOP in my practice, taking everything into account, cornea hysteresis, target IOP is huge, nerve fiber layer, all this stuff, looking at photographs, gonioscopy, until I get a really reliable visual field. Once I get a reliable visual field, I base my target 90 some percent of the time off of that worst eye. If that worst eye is less than 5, I do 30%. If it's between 5 and 10, moderate, 40%. And anything above a 10 is a 50% visual field, or a 50% off the target IOP. That's why I like to know what target is. I like to have a reliable visual field. 0 to 5 is 30, 5 to 10 is 40, anything above a 10 is 50. And I've been using that for years, and it seems to work really, really well. And at times you just have to modify it.
Yeah, the percentage reduction, we've got some of these major studies that had a 20, 25, and 30% reduction. And Greg, your algorithm it's very sound. When people pick numbers 20%, 25, 30%, okay, in my practice, we have a drop down in our medical record, and it's 15% pressure reduction has been achieved, or there's a plan to achieve this reduction. Keep in mind, when these studies are developed, they're not looking for what they think is the best number. They're looking for a number they can reasonably get. Most of these studies won't actually have a 50% pressure reduction, because there's a challenge in getting a pressure down that low. Although with some of our medicines now, we can certainly do it. But in the OAT study, they had a 20% pressure reduction as a target. In the normal tension glaucoma study, they had a 30% pressure reduction. And the early manifest glaucoma trial, they had a standard therapy which gave a 25% pressure reduction. But these are numbers that were chosen because they were reasonable to achieve. And what I want to point out is, in the course of these studies, there are patients who got worse with a 20 to 30% pressure reduction. But the collaborative initial glaucoma treatment study, which had a medical and a surgical arm, which had better pressure reduction of 35 and 48% respectively, by and large, they didn't get worse. And the AGES study, which is a surgical study, which had probably the most aggressiveness, where they're looking for under 18 in all visits, by and large, they really didn't have any pressure reduction. So keep in mind, when you choose pressures of 20 to 30% pressure reduction, you can get worse. These patients can get worse. And when you start hitting or going to the 40s and 50s, as Greg said, for the more advanced disease, you're probably going to have a better outcome in those patients. So don't overtreat those at minimal risk of vision loss, but don't undertreat those at high risk of vision loss. And don't focus on the pressure to the exclusion of other factors such as overall health, quality of life, life expectancy. And because we're ultimately treating a patient, we're not really treating the number. Greg, any final thoughts?
Well, no final thoughts on that, but we're getting some questions rolling in here on tonometry here, which kind of fits in nicely. And I think we can probably tag team some of this here. The first one comes in. It says, and this is from our colleague that's in Japan. Thank you for you direct message me, so I won't bring your name up. So, but thank you for serving, and thank you for taking these courses. I know you have a Florida license. You need to get the credit. So thanks for taking these. Any thoughts on patient monitoring at home with a product like the personal eye care unit? I think it's called the eye care home. And I can speak on it, Joe, because I have it in the practice if you don't have it. So I do have it in the practice. I believe that's called rebound tonometry. There's different types of tonometry that's out there. That's rebound tonometry. I like having that because, and I'll do it every so often on a patient just to kind of see what's happening with their diurnals, with their diurnal pressure, especially if I have someone that is below target and they're progressing and they're swearing that they're taking their drops. I've been able to solve a few kind of, hey, look at them spiking, look at their diurnal, look what's happening. You give them this device, you train them on how to do it. They can't see the readings. You plug it into a USB port and it downloads it. It's not something that I do all the time. It's kind of cool to, in these kind of special situations, to kind of troubleshoot. So just like anything out there, whenever you're doing a lot of it, and I do a lot of glaucoma, if you're a carpenter and you're doing a lot of woodwork, sometimes you might not use this tool, but man, you're glad when you have it. And I'm glad that's kind of where I plug kind of that eye care unit in. Joe, with that being said, I'm not sure if you have any comments on that. I'll let you do that. But also, and I don't really have much comments on this, it says opinion on the through eyelid tonometer for ODs or in the ER docs. The ER doc, I think, is great, but I'm not sure. I don't have much experience with the eyelid tonometers. But your thoughts on any of the eye care home or the eyelid tonometers?
Eye care home is actually very easy to learn how to do. Most patients can do it. A study was done at the academy, and it showed it was a very easy technique to learn very quickly. And I think it's good information. And keep in mind, it doesn't give the patient the pressure reading. It keeps that secret because you don't want to get called at 11 o'clock at night. My pressure's 28. What do I do? Take your medicine. Through the eyelid tonometers, I don't know if there's anything new. I remember the ProView, I think it's called the ProView several years ago. It was a pressure phosphene where you actually push on the eyelid, and once they get a phosphene induced by that pressure, you stop, and it was the measurement of the intraocular pressure through the eyelid. That was a self tonometer that was done. I don't know if our attendees are asking about a different device. It was great if your target pressure was 17, because no matter what the IOP was, it always read 17. And I'm just being facetious. I didn't find that to be very helpful. Any other questions there, Greg?
No, but I'll make a comment that I thought of something with regarding the eye care. And whenever I send that home with the patient, I tell them, look, I don't want you checking your pressure like when the office hours are open, because I could do that, right? I want them to, if they're staying up late at night, and I do see patients in the wintertime, whenever the time changes, I'll stay 6 or 7 o'clock at night. When the sun changes, I'm done at 4:30. But, beyond 7, 8, 9, 10 at night, midnight, they get up to go to the bathroom, check it. That's where, really the key is, where I like to have that eye care home. I think maybe what the eyelid tonometer might be what our friend Roman was showing us a couple of times at the academy, Joe.
Okay, yeah, that one.
Yeah, I think that's what the one they're referencing. If you have any other,
I just can't remember the name of that one.
I think, was it the diatom?
Diatom, yes.
Yeah.
I actually think the literature on that one is pretty supporting, and it's been very helpful with scleral lenses.
Yeah, and that's where I think is the big breakthrough on that is the scleral causing the IOP. One thing that people haven't talked about is we don't have it in here, I don't think, is the ocular response analyzer. And I can tell you, I've migrated away from even doing Goldman's at the practice since we've had this in the practice, knowing what the cornea corrected IOP is based on cornea hysteresis, not on cornea thickness. That's a whole other soapbox that I can get on. But knowing the cornea hysteresis is pretty neat. Goldman can be really off in high IOP. So you have someone that comes in after cataract surgery, or if they're steroid responding, because that intraocular pressure is so stiff, and after cataract surgery, the cornea could be mushy up front. You could have a pressure of 50 and maybe be reading 25 in an eye. Because after cataract surgery, the cornea swells, the stroma is swollen, They can sometimes get that phacoedema. They have a really high pressure, and all you're doing is applanating just the front, but you're not really applanating the whole cornea. So there's really no perfect type of tonometry that's out there. You have to be careful with all of them, know what you're doing, whether it's rebound or applanation, or is it the ocular response analyzer type of that's out there. So just be aware. And cornea hysteresis is actually a biomarker for glaucoma. Cornea's central thickness is not. Remember, there's a difference between biomarker and risk factor, right? So when you have a biomarker, that means you're on your way going into that disease process, right? It's going to happen. Risk factor just means, that it's just a risk of it occurring. It might or might not. So just be aware of that. And here it is right here. Ben, thank you. It says it is the diaton. Thank you.
Okay, thanks, Ben.
And then Joe, there's a question here, and I'll let you run with it, and I'll answer it. It says, a new patient to me on 2 different drops, treated for 10 years. Treated for glaucoma for 10 years, seeing 3 different ophthalmologists over 10 years. Nerve looks normal. Is it good care to take them off and repeat all tests?
Well, if the nerve looks normal, you don't have to take. First off, you don't have to take them off any medicines to repeat tests. You do the visual field, it comes back normal, great. You do an OCT, it comes back normal, great. Maybe the patient had ocular hypertension or has a suspicious nerve and was a bad field taker. If I can show that the nerve fiber layer, nerve, and visual field are normal, I may consider stepping patients off of medicines. I've done that many times, where a patient who had a large CD ratio, I felt everything was normal. I took them off of medicine. They skyrocketed from 15 up to 18 after taking them off of 2 medicines, and they were fine. I also have one instance where I told the patient, I don't think you have glaucoma. I took him off the medicine. Pressure went to 42. Said, I think we should use the medicine and put him back on.
And I'm going to answer, I think it's good care. I might even say it might even be great care. And I'm probably going to say that it might even be 10 years or maybe even 15 years where they might have taken the cornea thickness and said, oh, your cornea thickness is thin and your pressures are 19 or 20, and we're going to raise your pressures to 24. That's my soapbox. Don't adjust pressures up and down. And maybe that's how this patient ended up on medication. So I think if you, like Joe said, you don't have to stop. If everything looks normal, let's slowly take them off. Have I stopped patients on glaucoma meds? Yeah, because they didn't have glaucoma. They might have had a funny looking nerve. They might have had other cornea thickness and applied different studies the wrong way and decided to treat this patient. So I think it's not only good care, I think it might even be great care out there.
All right, Greg, are we going to, are we close to our end, or do so a few minutes? We want to talk a little bit about advanced glaucoma.
Let me see if there's any, we started at what did I say? We started at 7:08. So we better do 2 more minutes, Joe, just to be compliant. And then we have to we have to go to about 7 or 8:48 Eastern Standard Time here. And then take questions. So let's go for a few more minutes. So just jump into something.
Well, I guess the question is, what do we do for patients with advanced glaucoma? What is the best treatment? First off, what is advanced glaucoma? These are people who have 10-degree fields. They've lost fixation. We can't measure the Snellen acuity. They don't ambulate very well. Their mean deviation is probably less than 12. They have one of the 4 paracentral points less than 0. These are all definitions of advanced glaucoma. And these are examples. Here's a patient, we can certainly see there's advanced disease here. But this one, there's not much field loss, but there's a paracentral defect, and that's less than 0 right there. And we actually take a look at the 10-degree, and we see how close they are to the fixation. And we have to start thinking about what do we want to do for these patients. And everybody always says this is the person that needs surgery, and that is something that we have to reconsider. The surgeries will often give better pressure reduction and better visual field outcomes than medical treatment for advanced disease. They may be non-adherent to their medicines or they may not respond adequately, but there's also the risk of vision wipeout, where patients can have catastrophic loss of vision due to an early, late, or no complication. And there is actually no evidence to adopt primary surgical intervention in patients with advanced glaucoma at time of diagnosis. And the International Glaucoma Review actually looked at this in advanced disease. And these are the thought leaders in glaucoma. And George Spaeth out of Wills Eye Hospital has pointed out that not all patients with advanced glaucoma will actually progress within the period of time that they are allotted to live. And if not taking into account the rate of change and the estimated years remaining is really inappropriate approach to patient care. And Felipe Medeiros has said, out of the Hamilton Glaucoma Center, said there's really insufficient evidence to suggest that primary surgery would result in a better clinically relevant outcome in patients with severe glaucoma compared to standard medical therapy. And Jeff Liebman out of New York, said in eyes with advanced glaucoma at presentation, a low pressure should be sought rapidly and efficiently and keep that low pressure. And treatment for eyes with advanced disease can be extremely effective, but only if the pressure reduction is significant and long lasting. These patients really are not necessarily doomed to blindness if we can get the pressure down low and keep it low. And it's a significant pressure reduction. And there's many reasons why glaucoma can be advanced. There's no access to care, not aware of the disease, they're not adherent. I'm just going to wrap up with a case that underscores how well we can do with advanced glaucoma. Doug was a 63-year-old male who was not adherent to therapy because when he lived in the Caribbean, he didn't have access to care. So when he was referred in to me, his pressure was 43 in the right eye and 60 in the left with open angle glaucoma. He had hand motion vision in his right eye and 20/40 vision in his left, with just a little bit of vision remaining in his left eye. And of course, you can see he's got advanced end stage nerves here. And this was the visual field, a 10-degree field in his good eye. Now, Doug can watch TV, Doug can read the newspaper, Doug can ambulate around with difficulty, but, as he said, he gets around his house okay. Now, this is what one might consider to be the nightmare patient. Now, surgery would probably be the surest way of getting his pressure down into the teens, which is where he probably needs to be. But this is a person who's at extreme surgical risk. And as such, we decided to embark on medical therapy. Ultimately, I got him on a regimen of timolol and brimonidine fixed combination Combigan, brinzolamide, and travoprost in his left eye. And in his seeing eye, we got him down to about 10 to 13. Never missed his appointments, always very thankful that things were as good as they were for him. And this is actually what happened to him over a period of time. This was 2001. This was 2005. This was 2006. This is 2008. And you can see over the course of 7 years with that pressure reduction, he maintained his functional vision. And he maintained the same functional vision for the next several years until one day I came into my office and there was a voicemail waiting for me, and it was his sister. And she left a voicemail for me to give him a call. She used to drop him off for his exams and pick him up. And I just had this bad feeling. So when I called her, she told me he had passed away of natural causes. But we had gone probably 8 or 9 years with the same functional vision on medical therapy. So these are patients who may not need the risk of surgery. If we can get their pressure low and keep it low, they're not actually doomed to blindness. They can actually do very well. So, Greg, I think with that, we've probably met our fiduciary duty of our time.
Yep. So we just have to answer the questions,
Very
and I'll
good.
try and answer this one because it could be a whole hour lecture. So I'll try and answer this one in a relatively short and kind of cliff note version. It says, what about OCT changes to monitor in glaucoma? So when it comes to OCT, there first of all, there's two types of OCTs now that we could do in glaucoma. There's regular OCT, which we're all familiar with, which I'll say is kind of B scan OCT. And then there's OCT angiography. You can also use OCT, but you said changes here. You can also use OCT anterior segment to get your central cornea thickness. It's going to be super accurate out there. So you could do anterior segment to get your central cornea thickness. Traditional OCT, you're going to be looking at nerve fiber layer, and you're going to look superior temporal, inferior temporal, looking at the nerve fiber layer. Most OCTs now, most of them all have some type of ganglion cell complex where you're looking into the macula. Remember, glaucoma affects the macula. So you'll be looking at thinning of the over time of the ganglion cell complex or compromise to the nerve fiber layer around the optic nerve in what's called the T-SNIT, superior temporally, inferior temporally. That's where you're looking for glaucoma. When it comes to OCTA, you can look at the radial peripapillary capillaries, and you can see some really cool dropout mimicking kind of those wedge defects. And since glaucoma affects the macula and OCT angiography, you can also look at the capillary density in the macula. So you can use OCT, OCTA, looking for nerve fiber layer, GCC dropout, looking for radial peripapillary. There's lots that we could talk about, but that's kind of the cliff note version. You just have to make sure you're looking in the areas where the glaucoma is damaging. Another question we kind of talked about a little bit earlier, Joe, and you answered it, so I'll let you answer it again, is what about offering SLT to patients as first-line treatment newly diagnosed?
I think it's a viable option. If patients have mild to moderate disease, there's any hesitation about their compliance, or sometimes patients just have that preference. They preferred that. It's not. It is usually not sufficient for people who have advanced disease. But if you have a patient in the pressure in the mid 20s, maybe the high 20s, it's probably going to reduce the number of medicines that they're going to need. It'll probably be effective for several years, and it is a very viable first line treatment in the right eyes.
And then Robert here has a comment on speaking on OCT. If there are changes over time, we have to also look at signal strength to compare scans, apples to apples. And that is 100% true. One thing that glaucoma patients usually develop over time are cataracts. So there's times whenever I'll make sure that I'll dilate the patient before doing OCTs or repeating OCTs that are out there. So yes, that's a great comment, Robert. You definitely want to make sure that signal strength or epiretinal membranes in the macula, PVD formation in the optic nerve area are not changing that structure. There's lots of dynamics going on in that eye. So more than just signal strength when it comes to OCT, epiretinal membrane, vitreomacular traction, adhesions, lots of stuff can be happening, PVDs that can throw off those measurements. But when strictly looking at glaucoma, it has to be reliable. And those are the areas that you look at. So.
And keep in mind that everything we know about reproducibility is done under very controlled environments with trained technicians. Some of our technicians have different abilities. We have to make sure that we have, as Greg says, really good quality images, make sure that everything makes sense. And I think it's important to look at both the macula and the nerve fiber layer so that you can see the trends. A change in one and not another makes me dubious. I should expect to see change in both.
Here's another good question that rolled in, and we were all taught this, at least, maybe, I'm not sure if they're still teaching it because I graduated in 1995, but I definitely got away from it over time. Joe, I'll let you start off with the answer, and then I'll fill in any gaps if there are any. It says monocular trials, yes or no? And that would be for pharmaceuticals.
Well, Yeah, generally speaking, we used to do monocular trials based upon the belief that the diurnal variation is the same between the right and the left eye. It's the same from day to day, week to week, and month to month, and that medicines will actually work the same equally well in each eye. And we have found out those assumptions were not actually correct. The diurnal variation is variable over time. It is variable between the right and left eye. It's not identical. And medicines don't work exactly the same in the right and left eye. So my belief is I don't do it any longer. I actually put it in both eyes. And then I see at least two visits what is the overall trend after I start to make a determination whether it works or not.
Okay. And then my only last comment on that is yes, there is neuronal crossover. So I don't do monocular trials anymore. I do use the medication in both eyes. We got a colleague out here that's being nice to us and said didn't want to broadcast it, but thank you, person, for doing this. It says the TQ CAT test and the survey for the last course. The TQ test with the survey is for the last course. So everyone that's out there, we'll double check that all out. Thank you for pointing that to us. If it's the wrong TQ test and the wrong survey, I'll get in touch with our IT person and we'll get that fixed relatively quick. So maybe even a second email tonight or a early tomorrow morning. So we apologize for that. That's out there. So thank you for pointing that out. With that being said, thank you everyone for attending challenging and controversial topics in glaucoma. Joe, thank you. Joe and I presented here tonight. We have Vanessa as our COPE administrator. We do have live events coming up in 2021. There's going to be hopefully 6, if not, there'll be 5. We're just not sure if we can get across the border. We're going to be doing some enduring CE. Just visit and find the website. So your post-event email will hopefully have the correct survey and correct TQ link. If not, we'll get that fixed for you. We'll hopefully get that fixed tonight, and if not, it'll be fixed by tomorrow. But please complete the survey. The handout will also be in these post-event emails. Vanessa is optometric education consultants conference administrator. She will send the information to ARBO for those states that take ARBO. For those who have Florida license, you supplied us your Florida license. We'll get that uploaded to CE Broker. Anyone taking this course for credit will receive an email certificate. It might take a day or two to get that, and then for it to hit CE or to hit COPE with the OE tracker, it might take a week because Arbo is getting killed with all these webinars that are getting on. So give Arbo about a week to 10 days for you to see it, and especially with the holiday season. We'll get things uploaded to CE Broker and that certificate of attendance. With that being said, I'm going to have Joe land this. Wait, I got a little note here from Vanessa. Vanessa opened up the link and it seems to be the correct exam we can discuss. So we'll figure it all out, guys. We'll have the right thing. I want to wish everyone a Merry Christmas, Happy Holidays, a holiday season. Thank you for taking this. We have the human trafficking coming up at the end, and then we have a bunch of webinars planned for the Florida docs and for the other states too, but I know the biennium for Florida ends in February. So thank you for attending. Happy holidays. Merry Christmas. Joe, final comments.
Same thing. Stay safe. We're very close. Good luck with your vaccinations. Merry Christmas and Happy New Year to everybody.